Hello everyone, and welcome to the State of Connected Health 2018's Critical Trends to Watch. I'm Ashley Ray Needham, and I'll be your moderator for today's webinar. We're ecstatic to welcome the CEO of Validic, Drew Schiller, who's going to break down how connected health momentum will impact providers, payers, and patients in 2018. Drew is the co-founder, CEO, and board director of Validic. He sits in a rather unique place in the industry with a perspective and experience as a patented technologist and successful business leader. As CEO of Validic, Drew seeks to bring unique ideas to the marketplace as a means to grow the innovation and integration of technology into healthcare. He regularly writes, speaks, and advises on these issues and has been featured in several prominent platforms such as NPR, Forbes, and Fortune. Additionally, Drew serves as a board member of the Consumer Technology Association and actively contributes to the CTA's Health and Fitness Technology Standards Division. Drew also serves on the eHealth Initiative's Leadership Council and Interoperability Workgroup and the Clinical Trials Transformation Institute's Mobile Devices Project, and previously on the Federal Advisory Committee's Joint API Task Force on MU3. Drew's company, Validic, is the leading provider of platform and mobile solutions that simplify data and device connectivity. It is Validic's mission to improve the quality of human life by building technology that makes personal data actionable. Validic's products securely deliver actionable health data from your population into your system, making remote monitoring and remote engagement programs more effective and efficient. Unlike homegrown solutions or data aggregators, Validic's products ensure that the experience of using patient-generated data is invisible to both the individual and the care provider. Over the next 40 minutes or so, Drew will shed light on the trends to know, the initiatives to launch, and the technologies to integrate into the coming year, leaving time at the end for your questions. Just a few technical notes before we begin. If you'd like to download the slide deck from today's presentation or a one-pager about Validic, please click the Resources List button at the bottom of your screen. The webcast is being streamed through your computer, so there's no dial-in number. For the best audio quality, please make sure your volume is all the way up. This webinar is being recorded and will be available on demand within 24 hours after the event. So watch out for an email with the recording. And lastly, begin submitting your questions in the Q&A box using the button at the bottom of your screen. Before we kick things off, feel free to join the conversation on Twitter following @Validic and using the hashtag HCTrends18. With that, let's begin. Drew, welcome, and let's hear about those trends.
Thanks so much, Ashley. Really appreciate the opportunity. So as we're looking at the 2018 State of Connected Health, the first thing I really want to highlight is that there are advancements in connected health and remote patient care in 2018. They're going to be driven primarily by a broader multi-year trend, which is the movement away from acute inpatient services to outpatient home-based monitoring services. And to illustrate this, what we're seeing in the market is really more digital hospitals, which are ambulatory telemedicine or virtual care facilities that leverage technology to diagnose, monitor, and provide care to patients in an outpatient setting. In fact, recently, Intermountain just announced a digital hospital that's coming online in 2018. It's joining others such as Mercy Virtual Health in St. Louis, which is really a leader in this industry, and that opened its doors in late 2015, actually in October 2015, so just over 2 years ago. And this broader connected health market shift is being driven forward in 2018 by 5 key factors that we're going to discuss today. So as we look into the factors that are really driving connected health in 2018, the first is that successful early remote monitoring programs that we've really seen a lot of for managing chronic diseases are laying a strong foundational groundwork for new standards of care. The second is that value-based care and new reimbursement mechanisms are starting to help drive continued progress toward advanced payment models. The third trend is growing healthcare professional shortages, largely physicians, are driving the need to increase workforce productivity. The fourth that we're going to talk about is going to be evolving consumer expectations, which are starting to compel providers to leverage new technologies available in the healthcare space in order to really engage people in new ways. And finally, we're going to talk about how the wide-scale availability of connected, affordable home health devices are starting to enable patient-generated data delivery in the clinical workflow in ways that just weren't possible before. Before we really kick off into these trends, though, I want to talk about what's led up to this point, which is really, since 2005, we've seen some really interesting things. The first is that the percent of growth of the U.S. smartphone penetration has really changed things dramatically for the consumers. So we went from about 2% smartphone penetration in 2005 to now we're at over 81% in 2016, when we ended 2016. The EHR adoption at that same point in time, we went from about 24% to over 90% EHR adoption. And the U.S. adjusted healthcare per capita spend in that same amount of time grew by 65%. And so I think it's a little bit difficult to see on the slide, but that's 2005 to 2016. And in that same amount of time, actually, since 2010, what we've seen is that the amount of digital health investment has grown substantially. And so because of this, we're now seeing that most patients now have access to smartphones or online technology in their pocket. Most providers are connected through modern EHRs where data delivery and data at their fingertips is possible. And we're also seeing an unsustainable growth in healthcare spend that we need to really keep track of. And to take advantage of all of these markets, there have been thousands of well-funded digital health companies that are taking new approaches to care delivery. This sets up a great opportunity for us to talk about the 5 trends in 2018. And before we dive into these, I want to actually level set with a story about why this is important, why connected health is important, and the kind of care that is possible today. So this is Michael. Michael's 51 years old. He's a type 2 diabetic patient. To hear Michael tell his story, everyone in his family who ever turned 40 became type 2 diabetic. His father, his brother, his sister, his grandmother. When Michael turned 40, he was diagnosed with type 2 diabetes. He said, people think I'm fat, they think I'm lazy. The reality is I eat healthy, I exercise 5 days a week. I'm at the YMCA gym at 6 a.m. every day. I track my glucose readings. I just haven't been able to control my A1C. So Michael had an endocrinologist that he was going to for a number of years. And he was always frustrated because he would go in every 6 months for his visit, and the endocrinologist would adjust his diabetes medication based on an A1C lab value. There was rear looking. And Michael was frustrated because he was tracking his A1C, he was tracking his glucose every single day. And so his frustration was, why are you prescribing me medication that's based on a lab value that, rather than adjusting things in real time and helping me monitor my behavior in real time? So Michael actually took to downloading his glucose readings from his glucose monitor in a PDF every month and faxing that to his endocrinologist, which his endocrinologist kind of looked at and discarded because he didn't understand how to interpret the data. He didn't know what the glucose meter was. It was just not something that was actionable for the endocrinologist. So Michael was really frustrated, and because of this, he actually left. And he ended up finding a new care provider in endocrinology at Sutter Health. And the reason why Sutter Health matters in this instance is because the ONC, through Accenture Federal Services, in 2016 was looking at spinning up a couple of pilot programs to demonstrate how patient-generated health data can improve the quality of care for patients. And Validic, in partnership with Sutter Health, developed a type 2 diabetes monitoring program that tracks glucose values, blood pressure readings, weight readings, nutrition data, and activity data through a wearable tracker, fed the data into the EHR, into the care manager's workflow, and for the purposes of care. So shortly after Michael joined Sutter, he actually got enrolled into this program. And Michael said at the outset, I was ecstatic. That's all I needed to be an engaged patient, because my data that I was already tracking was going exactly where I wanted it to go on a daily basis, which is right in front of my clinicians and my care management team, and that's all I ever wanted. That in and of itself was enough to make me an engaged patient. But then he said what was interesting is that 2 weeks into the program, the diabetic nutritionist called Michael and said, hey, Michael, everything is looking really good. You're tracking your glucose, you're tracking your food intake, that's great. But what's going on between 7 and 9 p.m. at night? Because you're not logging any food, but your glucose is spiking. And so they were talking and they realized, Michael said, you know what? I realized I'm a snacker. My kids are in college, but they live at home. At night, we're hanging out, we're watching TV, watching a movie. There's chips, there's popcorn, whatever. And that, little handful of chips was enough to cause his glucose levels to spike. So he cut out the snacking, and within 30 days, Michael's A1C dropped by half a point, went from 8 to 7.5. And that was the first time that Michael was able to actually control his A1C through behavior change. And he says it's the first time he's ever actually felt like he could control his diabetes, that he could control his health through his own actions. And that was really empowering for him. And so this actually brings us to the first of my 2018 Connected Health trends, which is that successful early remote patient monitoring programs for managing chronic diseases are really laying the groundwork for new standards of care. In fact, one such study that's very similar to the ONC study that I just discussed, which unfortunately I can't discuss the results of that because the ONC is going to be publishing them later on this year. But there was a very similar study that was looking at a 6-month pilot for type 2 diabetics, and they were looking at could they control the glycemic values of patients. So what they did was they connected patients with telehealth devices, including a tablet computer, vital sign monitoring software, video conferencing software, health questionnaires, blood pressure monitors, glucose meters, and then care managers encouraged the participants to actually just use the video conferencing as the primary method of communication through the program. And the measurements and health questionnaires were sent via the tablets through the internet to a central computer running remote patient monitoring software. And the data collected were checked by care managers every day, and then response was based on individual clinical needs for the patients. And so the results of this program were actually really strong. It included over 60 participants, and it found that the HbA1c values for the remote care group actually decreased from a median of 8.4% to 7.5%, while the in-person traditional care group actually remained unchanged. So that's a big, big drop. The other interesting thing was the total healthcare costs for the remote care group, including intervention costs, were lower compared to traditional care by about $900 per patient. So the remote care program not only produced much better health benefits, but also cost savings for the healthcare system. And this is something that's not unique. We're actually seeing this pretty much across the board in all remote patient monitoring programs. We'll talk a little bit more about that in a minute. So there are a few factors that are driving the need for these remote patient monitoring programs. I'll talk about a couple here. One is an increased aging population. In the United States, this is an amazing statistic that I heard from AARP, which is that 2/3 of all Americans who have ever lived to be 65 are alive today. It's an amazing statistic. And 80% of the United States, U.S. adults in the United States who are 65 or older have at least one chronic condition, and 68% have at least 2 chronic conditions. That's from the National Council on Aging. Another interesting contributor here is social determinants. So remote patient monitoring programs can look at social determinants in a new way, much differently. In fact, if you look at risk factors for premature death, social and environmental determinants and individual behavior make up 70% of the risk factors for premature death. It's a really high statistic and something that you can actually attack directly with remote patient monitoring. These social determinants include factors like socioeconomic status, education, the physical environment, your employment, social support networks, and access to health care. And what's also interesting about this is that 88% of hospitals screen for social needs, but almost 40% of hospitals report having no capabilities to actually measure the outcome of those screenings. The third thing here is implementation of data analysis and machine learning. So in 2018, I expect to see artificial intelligence starting to be incorporated into population health management programs on a much broader scale. And really what we're going to start seeing is predictive models that are being used to notify things, for example, notify physicians of patient populations who are at risk through a remote patient monitoring program. So eventually we will likely get to a point where, the individual Joe Smith might be specifically at risk for a particular admission. I think today what we're going to see is Joe Smith, as part of a larger population, falls into a population bucket who's at risk and somebody who you reach out to. So, for instance, Massachusetts General Hospital identified cohorts of high-risk patients and developed a proactive care management program around this population. And the result was hospitalizations of these patients dropped by 20%, and their emergency department visits declined by 13%, and the annual cost of caring for them fell by 7% over a 3-year period. So mortality, physician satisfaction, and patient experience also improved. And finally, cost savings and consumer engagement numbers are dramatically impacted by remote patient monitoring. So there's actually a really interesting Accenture survey that found that 73% of providers report moderate to extensive operational administrative cost savings from their remote patient monitoring programs. 86% of payers report moderate to extensive medical cost savings from their remote patient monitoring programs. And over 90% of payers and providers report gains in consumer attraction and retention due to implementation of remote patient monitoring programs. So to tie this off here on trend number 1, we have done a lot of great groundbreaking work in the industry around the need for remote patient monitoring. And I think in 2018, we're going to start to see all of the evidence that we've laid out start to be realized in real broad-scale remote patient monitoring deployments. So trend 2 that I'd like to talk about is our continued progress with advanced payment models, including value-based care and new reimbursement mechanisms. So first, as healthcare moves more from the fee-to-service to value-based care, we're going to continue to see evolutions in advanced payment models to drive more general adoption for remote patient care programs and pilots. One really interesting statistic is that ACOs are continuing to gain traction and now cover roughly 10% of the U.S. population, which equates to about 32.4 million lives. And as of Q2 this year, there were roughly 923 public and private ACOs operating nationally. So that's a really encouraging trend as we're starting to see the shift toward value-based care. Second is that CMS just last week released new macro rulings that are taking effect for remote patient monitoring in 2018. Specifically, CMS has unbundled the CPT code 99091, which means that starting January 1st, providers will be able to get reimbursed separately for time spent on collection and interpretation of health data that is generated by a patient remotely that's digitally stored and transmitted to the provider, and the provider spends at a minimum 30 minutes of time each month looking at this data. And so what's exciting about this too is that CMS has stated that this is just a first step toward recognizing remote patient monitoring services for separate payment. So the highlights here, this is a revised rule, 99091, that takes effect on January 1st, 2018, reimburses providers $57 per patient for a 30-day period for collecting and reviewing remotely monitored data. And finally, providers need to spend a minimum of 30 minutes reviewing the data for each patient. What's really important about this 99091, as well as the ACO trend, but specifically the 99091 CPT code, is that as I talked about the story with Michael in the beginning and the success he had with the ONC pilot, in the past, these remote patient monitoring programs were really challenged in a traditional fee-for-service world because Michael received a lot of proactive care, and there was not a mechanism for reimbursement for the care that the care managers and the diabetic nutritionists, as well as the endocrinologists, spent really reviewing the data that was coming through. But the unbundled 99091 CPT code is a big step in the right direction toward covering proactive remote patient monitoring programs. So, the third trend. Growing physician and healthcare professional shortages are really going to drive the need for increased workforce productivity. So according to the Association of American Medical Colleges, the U.S. is facing a shortage of between 61,700 and 94,700 doctors by 2025. It's a massive shortage, tens of thousands of physicians. And a study also shows that nearly 2% of physicians plan to leave the field within 2 years because of burnout, largely caused by the EHR, which adds to the physician shortage we already expect. And then moreover, more than half of all physicians rate their morale as negative and would not recommend a career in medicine. So this is a really sort of disconcerting trend in healthcare. And what's also interesting is that demand for nurses is also outpacing supply. So according to the Bureau of Labor and Statistics, we have about 1.2 million vacancies for registered nurses between 2014 and 2022. That's what the estimate is. And as you can see on this slide here, physicians currently are spending about half their time in the EHR as opposed to interfacing one-on-one directly with the patient. And this is leading to the feeling of physician burnout. It's leading to that dissatisfaction that's causing physicians to churn. And the key takeaway here is that technology is supposed to be an enabling function. It's supposed to be something that helps us be more efficient and improves our productivity. But I think what we've seen historically is that technology in the healthcare setting has actually reduced productivity as well as made jobs somewhat more difficult. And so the way that I think we're going to start to see technology be utilized in a much more proactive way, in a way that is actually an enabling function, which is really what it should be, is through remote patient monitoring programs like the ones we've been describing. In fact, if you think back to the O&C pilot that we did with Sutter Health, in that pilot program, the reason why the care management team was actually able to provide really proactive care for Michael is not because there was somebody who every single day they were scrubbing all of the individual data points and reading through large, vast amounts of data and processing it and running pivot tables in Excel. It was actually because what they did was they brought the data into the EHR and populated a prioritized care list, a stratified patient list for their patient population. And so every morning a care manager would come in and it would just flag individuals when individual readings or other trends were set outside of a range. So it made them actually much more efficient in managing a diabetic population, whereas generally speaking, that would be a very manually intensive process and a lot of phone calls involved. So I think there's a lot of opportunity there. Trend 4 is evolving consumer expectations that are compelling providers to leverage new technologies. So if you think about how Michael was seeing this endocrinologist, and he was really frustrated because he wasn't getting the proactive care that he felt he needed, and he knew that he was collecting data that could be used to manage his care, but it wasn't being used, Michael went out and found a new provider. And guess what? He's actually not alone. There's a survey from West Health that found that 88% of patients would switch providers without hesitation if they were dissatisfied. And almost 2/3 of patients agree that healthcare in America does not effectively help those with chronic illnesses manage their conditions. So in an increasingly competitive landscape, it's critical that healthcare organizations devote more attention to improving satisfaction among chronic patients. And communicating with patients at home in the course of daily life is one way that providers can successfully engage patients and improve satisfaction. In fact, 66% of patients with a chronic condition say they'd be more likely to stay with their healthcare team if their personal health data was monitored remotely and interventions were made if something appeared wrong. So just like Michael said, the fact that my data was just being connected into the care team, that in and of itself made him an engaged patient. 2/3 of surveyed people agreed with him there. And they also said 2/3 of chronic patients also said they'd be willing to pay extra up to $10 per month for between visit support. And in fact, we saw this anecdotally in one of our early remote patient monitoring programs for hypertension. We were working with a research organization in California, and we were helping them remotely monitor a few dozen patients for hypertension, and it was a 3-month pilot. At the end of the pilot, the care team went out to collect the devices from the patients who were in the program, and the patient said, well, we actually don't want to give this up. And they said, well, we're sorry, like, the program was only funded for 3 months. And the patients actually offered, can we pay to stay in this? We're finding a lot of value in this. So there's a lot to the patient satisfaction component for being involved in these remote patient monitoring programs. And finally, the last trend is that wide-scale availability of affordable, connected, in-home medical devices are really going to enable patient-generated data to be delivered in the clinical workflow. So thinking back to the ONC pilot, where Michael saw his A1C drop by 0.5 point, if you think back to what he actually did, what Michael himself as a patient did, he didn't do anything differently. He was already tracking his glucose. He was already exercising. He was already tracking what he ate. He was already doing all the things you would expect an engaged patient to do just because he felt like it was important to try to manage his condition. Now, Michael is an outlier in that respect, but the point is he was already doing the things you would want him to be doing. But by simply integrating the data that he was already tracking into the clinical workflow and into a program of care that set outcomes goals for him and the clinician staff, that just changed his life. That enabled him to feel like he could actually control his health with his behavior, which is the first time he ever felt that way. And the data available from consumer and clinical devices today is more than sufficient for remote patient monitoring purposes. So there's a couple considerations for including consumer and clinical device data in remote monitoring programs. The first is that physicians already have a plethora of raw patient data in the EHR. They already have a lot. So it's important that we don't just deliver more data. In fact, I often hear, I don't need more data. And I would say if you implement a remote patient monitoring program and you feel like you're just getting more data, you're doing it wrong. What you really need is for actionable information to be delivered in the clinical workflow to improve efficiency of the care team and the clinicians. The second consideration is that you need to seek to understand which devices will deliver the trusted data to achieve the outcome measurements you're looking for in the program. It's really important to develop a program of care where the care team, the clinical staff understands what devices are being used, how the data is being collected, where the data are going, which elements of those data are actionable, which thresholds are actionable, when you want to actually use those data for the purposes of care and outreach. And getting the right data is really, really important. So as I mentioned earlier, we must implement the technology that makes providers and care teams more efficient and more effective. And the way to do that is you need to bridge the continuous data model from in-home medical devices and consumer devices with the episodic care model of the EMR. So this means leveraging technology that enables you to set alert thresholds and exception data. For example, it's important to know that somebody didn't take a reading. Maybe it's important to know that a hypertensive patient didn't take a blood pressure reading within a 72-hour window. That's not data, it's the absence of data, but that might be something that's actually more actionable than the blood pressure readings themselves. So being able to set those signals in the right way so you're getting signal, not noise, from the data. And additionally, you can use the data from these devices to implement care views and help prioritize time. So as I mentioned a few minutes ago, in the ONC pilot, the clinicians used data collected in the real world to power a care management dashboard. And that actually had a prioritized sort of red, yellow, green stratified patient listing to illustrate how patients were performing in the program. So each morning, a care manager would come in, they'd review the dashboard, they'd reach out to patients with a red designation that typically indicated, readings weren't being taken or the readings fell outside of a predetermined range. And by really separating that signal from noise, data from the wearables and the in-home medical devices can provide greater remote care and efficiency for both providers and patients and give them the peace of mind that's needed to participate in these programs. And finally, on the subject of choosing the right devices, there's a couple of things that are going on that started in 2017 are going to continue in 2018 around device selection and how you should really think about finding trusted data sources. The first is that the FDA issued a new software pre-certification program in 2017. It's a really exciting pilot program. The program aims to evaluate a new approach towards software products that includes a pre-certification for the assessment of companies that perform high-quality software design and testing. Initially, it's a voluntary pilot program. It's part of the FDA's ongoing efforts to develop pragmatic approaches to balancing efforts and risks of digital health products. And the FDA intends to develop a pre-certification program that could replace the need for example, a pre-market certification or submission, and in some instances, actually allow for decreased submission content and potentially faster review of marketing applications or software products. It's a very, very exciting program for the FDA. They're really being forward-thinking in terms of how they drive innovation, and they set the right guidance and put forth the right regulations, but also are still encouraging the pace of innovation to continue at the rate it's continuing at today. And second is that, as Ashley mentioned at the top in my introduction, I'm on the Consumer Technology Association Health and Fitness Technology Division Board, and that board has a corresponding standards body. And then we've been developing ANSI standards around some of these devices, such as physical activity monitoring, which we have an ANSI standard for steps, the first ANSI standard for physical activity around steps. And then we also have a pending one for heart rate that I believe has just been finalized or is about to be finalized. So we've set physical activity monitoring standards there. The group is also getting ready to set a standard around sleep data and also EEG data with more to come. And the Health and Fitness Technology Division recently also signed on to the ONC Interoperability Pledge to indicate our support for data sharing for consumer technology companies. And finally, the Health and Fitness Technology Division is also working really closely with the FDA, CMS, Office of Civil Rights, and other government agencies to ensure that patient privacy and security best practices are followed. So it's two really good groups, the FDA and CTA, doing a lot of work in this space to provide trusted data from these devices. So, in summary, in 2018, connected health is really going to be heavily influenced by this broader movement of hospital-based care to home-based care. And second, the trends that we discussed are first, successful early remote monitoring programs for chronic diseases are laying the groundwork for new standards of care. Second, that value-based care and new reimbursement mechanisms are helping drive continued progress toward advanced payment models. So if you remember, the new CPT code from CMS 99091 is a really important code to look into and watch as that continues to progress. Starts January 1st. The third is that growing healthcare professional shortages, largely physicians, are driving the need for increased workforce productivity. Fourth is that evolving consumer expectations are compelling providers to leverage new technology. Again, if you think back to Michael, he got really frustrated with his endocrinologist for not actually leveraging the data that he was collecting in the real world to monitor his condition. And so he left and found another provider. And 88% of other Americans agree that would be their choice as well. And finally, wide-scale availability of connected, affordable, in-home devices are enabling patient-generated data delivery into the clinical workflow in ways that have never been able to be possible before. Thank you so much, and I look forward to the questions.
Thanks, Drew. We have a lot of questions submitted, so we'll try to get to as many as possible. If you don't hear a response from Drew on your question today, feel free to email hello@Validic, and we will coordinate getting a follow-up to you. So with that, let's dive in. Drew, can you talk a little bit about what the low-hanging fruit for healthcare that can be solved first?
Yeah, sure. I think the low-hanging fruit is, kind of what I illustrated with the ONC pilot and Michael's story is that a lot of the technology that's needed to implement remote care programs and really drive healthcare further and improve patient care, as well as physician experience, already exists. And the key is really to just bridge that technology with the current care models of today. So if we could leverage the EHR functionality that's already in place, leverage the population health management platforms that have already been deployed and map the continuous data model from these devices in the field with the episodic care model of how clinicians and care managers are used to delivering care. I think that's really the low-hanging fruit. We can develop some really powerful, impactful programs.
Great. How will AI and analytics impact healthcare at scale?
Yeah, so I think short-term, analytics are going to be used to really help identify important trends and outliers for patients who are at risk. Long-term, I think we're going to see something that's maybe a little bit more specifically tailored. But, for example, I know of a company that's using electronic health records to determine who in a patient population is at increased risk for early-stage cancer and therefore should probably receive advanced screening, which I think is a really interesting application of the technology and something that could meaningfully impact patients' lives. And while you're not going to have 100% of the patients who get screened receive the diagnosis, they have shown that for some percent of patients who get screened, they actually do end up having early-stage cancer, and of course it's always better to catch it at early stage. So that's the kind of intervention that I think we're going to see using AI and analytics today.
And you kind of addressed this earlier, but maybe you can dive a little deeper. But what do you see as the biggest barrier or one of the largest barriers to adoption of remote care?
Yeah, one of the biggest barriers is that while I did mention that we have a growing body of evidence around remote care programs, we don't yet have enough data for these programs to be considered the standard of care across disease states. And so, we at Validic and other organizations are really working on creating sort of, base states for diabetes, for hypertension, for cardiovascular disease, but there's still a lot of work to be done around how these data can be used to improve, efficacy long-term for other chronic conditions such as asthma, as well as acute conditions like oncology. So I think there's just a lot of work to be done to get from sort of where we are today to really being the day-to-day standard of care for any patient with these conditions.
And how do you see remote care tackling the prevalence of comorbidities among chronically ill populations?
Yeah, that's a great question. So this is actually something that's really near and dear to my heart because we see a lot of folks through our customer base who have multiple comorbidities, and in fact, many patients with diabetes have pre-hypertension, or many patients with hypertension have depression or stress-related conditions, and so comorbidity is something that's very common. In fact, I think I threw out a stat earlier that 2/3 of Americans who are over the age of 65 have multiple comorbidities. So I think that the opportunity is that when you implement a remote care program, you can actually start to, instead of thinking about a remote care program for diabetes or a remote care program for hypertension, you can start to think about leveraging a device-agnostic mechanism or a data-agnostic mechanism for running these programs and actually create a sort of a subsection program and create a remote care program for type 2 diabetics that also have pre-hypertension, or a remote care program for hypertensive patients that are pre-diabetes or pre-diabetic and maybe also have or at increased risk for depression. So I think there's opportunities to break apart how we've been thinking about the traditional swim lanes in healthcare. And I think that there's a lot of factors that are going to go into that in order to make that happen, but it's not a technology problem, which is what excites me.
How do you envision physician adoption of consumer device-driven data within the electronic health record?
Consumer device data, so in terms of like wearables, for example?
Yes.
Yes. So I think that there's, certainly as we're thinking about Fitbits and Apple Watches, et cetera, there's a huge prevalence of these devices out there. One of the biggest challenges is the continuous data model mapping to the episodic care model. So in terms of, so I'll take this in two ways. First, certain health systems want all of the data to go into the EHR and that come in from the outside, and certain health systems actually want the data to go into a separate database that lives outside the EHR. Whichever solution your particular health system decides to use, it's really important to bring in, to be able to bring in actionable data from those insights and view it inside the workflow. So if you're talking about Fitbit data, Apple Watch data, Nokia data, et cetera, what you really want to be able to do is highlight the trends of the wearable device with the trends of other health outcomes that you're tracking with that patient. So if you're bringing in, blood pressure monitoring results or heart rate results or glucose monitoring results, being able to lay the trends of those graphs together and start to see interesting thresholds, I think would be important. The way we're actually seeing this used in practice is that if you could look at maybe a diabetic population, for example, you could alert a clinician or a care manager on a physical activity trend where maybe the physical activity has decreased by 1 or 2 standard deviations from normal over the course of a week. So that's an instance where there's a meaningful decrease in physical activity that's likely to indicate that something else is going on, and that's a pretty simple alert or threshold to create that makes the data really actionable and gives you something that you can reach out to somebody for.
So we've got a couple questions about cybersecurity. Putting them together, how will cybersecurity issues affect the adoption of connected health devices, and how does it affect the integration into clinical care programs?
Yeah, so cybersecurity is obviously a really big challenge in healthcare and a very hot topic, especially anytime you're bringing data in from the outside. And I think this is why some health systems like to bring in the data or like to keep the data living outside their EHR and use the EHR primarily for their clinical care. And then other health systems, though, choose to bring the data actually into the clinical environment. Whichever way you choose, the way I think about cybersecurity is that it's really important to limit the number of outside interfaces and the number of outside interactions that you have with vendors, which can be a challenge because there are dozens of wearables that people wear on any given basis. There's literally hundreds or thousands of home monitoring devices that they could be using, that patients could be using. Validic connects with over 400 disparate data sources on our own. And so if you can leverage a service, like Validic or something else where there's sort of a one-to-many adapter where the data coming off those devices has already been delivered in a secure manner, has already been standardized and normalized in that environment, and then there's a security screen and a secure interface between that many-to-one adapter and the health system. I think that's really where you can have a pragmatic cybersecurity strategy while still enabling sort of a BYOD interface.
Great, and there's been some questions about who could possibly regulate these devices. So will we see the FDA-approved commercial devices like the Apple Watch or Fitbit, or is this going to come from an outside group?
I think that in terms of regulation, I think that we'll see the FDA go as far as they've gone with this pre-certification program, and we've seen Fitbit and Samsung and others join this FDA's pre-certification program process, and that's intended to be a streamlined process that's just that sort of checks the boxes to make sure that the messages are consistent, that the security is there, et cetera. I don't see the FDA going too much further than that, just because of the previous guidance they've given on some of these wearable devices. They actually have a wellness data report that came out about a year ago that illustrates how the FDA looks at wellness data. In terms of other regulations, so the Consumer Technology Association is doing some work here that would enable potentially like a pre-certification program. There's also groups like Exercia that's working with the American Medical Association that's doing some work around app certification. So there are some other bodies that are doing work in this area, and I'm actually happy to report that that the Consumer Technology Association, the FDA, and Exertia, as well as AdvaMed, are actually all working together to develop a cohesive strategy across the organizations so that there can be, sort of one streamlined process, and it's very easy for a device manufacturer to understand where they can go to get the appropriate certification to bring the trust into the audience, or to bring the trust into the provider system that they need to have.
Great. Well, thank you, Drew. That's all the time we have for the questions today, and thank you everyone for attending today's webinar. A special thank you to our speaker, Drew Schiller from Validic. I hope you all have a great rest of the day and week. If you would like to learn more about Validic, please visit validic.com. Thank you.